Hey, hi, good evening, everybody. This is Dr. Roshli from the medical team of USV, and a very warm welcome to everybody for yet another episode of CME India, and where we are going to discuss about the essential echocardiography learnings for physicians. It is so vital. Without further ado, I would like to invite the driving force for this group, CME India group, none another than Dr. N.K. Singh, sir. Needing absolutely no introduction. He's the director of the Diabetes and Heart Research Center, Dhanbad, chairman RSSDI Jharkhand, and an executive member of National RSSDI 2024 or 2022 to 2025. Also, the ex-governing body member of API. I welcome you, sir, on behalf of Team USV, and it's great to hear from you again.
Yeah,
With this,
welcome all the audience and our respected Dr. Rakesh Gupta, Dr. Ashok Garg, and our Dr. Bijay Patni has joined. So can you go for the slide, CB slides of Dr. Bijay Patni first? So welcome, Dr. Bijay Patni. Due to some medical emergency, Dr. Ashish Saxena will be not joining today. So I am really thankful to Dr. Rakesh Gupta. I think hardly he needs any introduction in the field of echocardiography. So Dr. Bijay Patni is also moderate today's session. He is a current reason are the HOD Diabetes Wellness Clinic, Kolkata, and lots of membership, lots of research. I think you are well aware. So Dr. Bijay Patni, now I request you to formally introduce Dr. Ashok Garg and request him to introduce Dr. Rakesh Gupta because he will be presenting today's talk. Dr. Bijay Patni. So next slide.
Thank you, sir. Thank you.
Yeah.
So we have Dr. Akash Garg, who is moderating this particular session. He's the Director Clinical and Non-Invasive Cardiology, Priyanka Hospital and Cardiac Center, Jaipur. He has fellowship of Indian Academy of Cardiography, International Society of Cardiac Vascular Ultrasound, Royal College of Physicians of Edinburgh, and CSI. He is first in the world to report the pulmonary valve involvement in the lupus endocarditis, first to report the reverse offsetting of atrioventricular valves, and reported the youngest case of spindle cell sarcoma in RVOT till date. So, welcome, sir. It's over to you.
Ashok Garg sir, kindly introduce today Dr. Rakesh Gupta.
Sir, Dr. Rakesh Gupta sir needs no introduction.
Yeah.
First introduction is he is my esteemed teacher. Whatever echocardiography I have learned, I learned from him only. He has taught so many students echocardiography all over India and globally. You can say like more than 3,000 doctors. He has taught the echocardiography, and he's running echocardiography courses also. And he's the former cardiologist at Thomas Jefferson Institute of USA at Philadelphia. He's visiting cardiologist at Fortis Hospital, Saket. He's adjunct professor of cardiology at Parul University. He has been the president Indian Academy of Echocardiography. He's associate editor of Indian Heart Journal also. He has been the president. He has served as president Cardiology Society of India. He has been served as editor-on-chief in Journal of Indian Academy of Echocardiography from 2012 to 2017, and he has been the chairman of Accreditation Test Committee of Fellowship Program of Indian Academy of Echocardiography from 2002 till date. So I think it's over about Dr. Rakesh Gupta, sir.
Good evening, everybody. Thank you, Dr. Singh, for giving me an opportunity to talk on this platform. Dear Ashok Garg, dear Dr. Akash Singh, and in absence, Ashish Saxena, who was going to deliver this talk, I'm here at the last minute. I hope I should be able to do justice to this particular program. Well, thank you for my introductions, and I would like to say that this is where I work as on today, Giraffe Institute of Echocardiography. We have trained more than 5,000 people in last 25 years of our career in our place. And we are celebrating 25 years of our existence on 17th August 2025 in Delhi. Well, if you look for a physicians, what he should look for in echocardiography, believe my words, in this whole traffic, wherever you look, there's a role of a physicians if you have to look for an illness. And that's how I believe it. It's not a small micro word that he has to look for a single thing. I say Wherever you look, there's a slide empty tells you that everywhere there's a role of a physicians as on today. Fortunately, unfortunately, many of our international colleagues now they're venturing into echocardiography, especially for structural heart diseases. And how did they land to structural heart disease? Only through physicians. Second important thing is who comes across all these conditions, especially the acute MIs, acute cerebral vascular accident. It's a physician first. And it is the physician who makes a tentative diagnosis, finally proved by a cardiologist, and then done an interventions. So the physicians plays a significant role in early detection, proper management, and final good outcome and a good prognosis. Let's start one by one. What is the role of physicians? Here's a patient who's just 50-year-old, presented with a chest pain in casualty. ECG showed evidence of acute ST elevation suggestive of anterior wall MI. Significant ST elevation in V1, V2, V3, V4. And we have a reciprocal depression in lead 2, 3, and AVF, along with maybe something we can see in lateral leads, but I'm not really sure. And all of us will say that possibly patient is having an extensive anterior wall MI. Well, very true. Whatever they said is correct. But I have to prove something beyond that what is the role of echocardiography? Here is an image of a 3-chamber view. This is a posterior wall and this is anterior septum. If you look carefully at this anterior septum, this basal anterior septum is contracting, the mid anterior septum is almost hypokinetic to akinetic. And same thing if you look at in this particular window of 4-chamber view, apical septum and apical lateral wall is hypokinetic. 2-chamber view, apical inferior and apical anterior wall is hypokinetic. I'm going to play them again. Now you can concentrate on this, like something like a bulge kind of a thing which is happening outside, which is almost akinetic in this segment. But the most important thing is, look, he's got a preserved endocardial thickness, suggesting that myocardium is still wide. Well, everybody appreciate that this patient should be referred for angiogram. Now look at the same patient, same ECG, but a different presentation. What is the presentation? Now look, whole of the anterior apical segments are akinetic, and he has got a linear thrombus in the apex. In same 2-chamber view, apical anterior, apical inferior wall is akinetic. And here the most important thing, if you happen to look at carefully, like this patient has got mid and basal anterior septum, which is akinetic. Now the question is, why 2 different echoes in the same kind of a patient with the same ECG? And if I put them together, and that's what you like to look at it, here is one patient who has got only mid-anterior septum, which is akinetic, and now here is a patient who has got a basal and mid-anterior septum, which is akinetic. And that's what exactly made a different. And this patient has got an apical thrombus as well, though the ECG was same. What is the answer? The answer lies with the slide shown over here. The answer is, look at my LED. LED supplies to D1 branch to basal anterior septum, D2 branch to mid anterior septum, and finally the D3 into the apical anterior septum. If I've got this patient who has got basal anterior septum which is contracting versus not contracting, it means to say that this echo tells you, look, if its basal anterior septum is not contracting, we are dealing with proximal LED lesion. Very true. If the basal anterior septum is contracting, then we are dealing with mid anterior septum. And finally, if we happen to see the basal anterior septum and the mid anterior septum, which is contracting, only the apex is gone, we are dealing with apical anterior septum territory. So that we are dealing with proximal, mid, and distal LED lesion. Now, what is the significance of this particular phenomena for a clinician? I can quote an example. When I taught these things to my student when they went back, one of my students called me up, sir, I saw a same patient. Patient had a basal anterior septum which was not contracting. And as per your wisdom, as per your thought, I referred the patient to immediately the near intervention center. By the time in next 30 minutes, the patient reached to the intervention center, his pulse was 120, his BP was 80, from 120 to 80 to only 80. What was that? And immediately they did interventions and they found the LED was fully loaded with the thrombus. My quest of showing this particular image is, look, if you look at an echocardiography with the same kind of an ECG, look, the same patient, one is this and second is this. There's already a lot of thrombus burden over there. The clot and LV has started becoming a little bigger inside with proximal LED lesion. These are the people who have at a very high risk of developing a high cumulative mortality and morbidity. Action is at the level of physicians. As soon as the patient reaches the intervention center, they can be tackled very easily, but it is the physicians who makes a difference. And that's why I would like to say this word. Look, who makes a difference for a patient survival? It's not a cardiologist. It's a physician who at the helm of affairs when we are dealing with this kind of a lesion of LED. And it has happened number of times, number of students, we gives you a call, sir, we did this and my patient is alive today. Same thing happens in other places also. They don't have a facility for about 4 hours, 5 hours of the drive. They struggle a lot. Many of the patients survive and many of the patients, they do not survive. And that's how this echo in CAD really makes a difference. That's one thing I showed you, which is a common importance today. Well, echo in CAD is a chest pain with a abnormal ECG. That's what I showed you. You can have a chest pain with normal ECG. And this is where, if you are suspecting, put them on a physiological stress. I would like to say these words, a physiological stress is much better than a pharmacological stress. One, it tells you about how much exercise or meds he can achieve. Two, as soon as the patient becomes symptomatic, you can really stop the treadmill, look at an ECG and do an echocardiography. And third important thing is it helps you differentiate whether the chest pain is cardiac versus non-cardiac. Now, you have an abnormal ECG, you had a post-PTCA, now you want to assess for viability. You can do a low-dose dibutamine in these subset of populations. Then last comes post-PTCA evaluation, post-CABG. I did a CABG. I want to evaluate how is my patient doing after CABG. Either you go for a CT scan. Many people are looking for a CT scan. But I can tell you, whatever you do, nothing better than a physiological test to assess their coronary artery status. Any questions? Dr. Singh would like to take this question in the end or in the beginning?
Sir, I think at the end we will discuss, sir.
Perfect. So this is how we play a role of echocardiography, where ECG is abnormal and a patient presenting with chest. Let's move to this person who's just 40-year-old male and a history of hypertension for more than 12 years. Look, there has to be some reason if this guy is a 40 years, has got a 12 years of hypertension. And majority of this time, the hypertension has been associated with epistaxis. I say is a pressure cooker valve, and he had the number of this epistaxis in last 12 years. And every time he went to an ENT specialist, they packed up his nose, tried to control his blood pressure, and then come back again to the same thing. He developed a renal stone, went for a renal stone surgery also. And it is written in the notes that this patient was very difficult to control the blood pressure. Now the renal stone was removed and still he was having an uncontrolled blood pressure. Now, one single thing which patient makes a difference when he walks to us, he says, sir, when my BP becomes normal, it becomes very difficult for me to walk. And when my BP is normal, I'm absolutely fine to walk. We heard him and it struck us something, but we wanted to prove it over a period of time. When we looked at this time, he was off medicines. Blood pressure was 200/100. Pulse was 70. He was on multiple drugs, not taking any more now. And systemically, we could not detect any significant abnormality. Then ECG shows LVH changes. Obviously, T-wave changes in lead 2, 3 AVF. V3 to V6, and they did suggest hypertensive heart disease. Now look at this echo very carefully. Hypertensive echo, very simple. Look, this is a plaques view, RV, aorta, LA, LV, and this is interventricular, anterior interventricular septum in the posterior wall. Some amount of a regurgitation, we can say a trivial mitral regurgitation just behind of it. Very good contracting LV. If I go to short axis view, even short axis view was contracting very good in this patient. Saying that this, whatever the changes we were having in ECG was having possibly because of this left ventricular hypertrophy. I'll try to prove it next in 15 minutes, in 2 to 5 minutes time. We went on to do a four-chamber view, LV, LA, RA, RV, and look at a beautiful contracting of the septum and the lateral wall, then beautiful contraction of the inferior and anterior wall, and similarly the contraction of anterior septum and posterior wall. And that's what we look for. We look for a good amount of ejection fraction, 66% LV hypertrophy, and nothing significant as far as the valves are regurgitated. Everybody will have to say that, look, this is fine as far as echo is concerned. This guy is reasonably okay, and we need to look at his cause of hypertension. Well, LV function was normal. Normal diastolic function by EA ratio, the 4 or 5 parameters which will come later on. Then we are doing nowadays evidence of concentric LVH, remodeling, eccentric hypertrophy, or normal geometry. This is a very good method of looking at a left ventricular hypertrophy. Regional wall thickness was more than 0.6 with a mass of 140. Normal is 0.42. For a male, 115 grams per meter square is a normal value. Putting these things together, we said that possibly they correlate very well with ECG finding. But what is the cause of hypertension? That's what we wanted to emphasize in this patient. Look, when we saw this echo, we looked at a hypertrophy in a person who's just 40-year-old with a 12-year of history of hypertension. We need to look at least two things in a life. Look at a descending aorta. Many of you sitting over here, you'll cross-questioning me, descending aorta at the age of 40 years? Well, I'm not saying that. This is a patient. I can show you this. Here's a patient who's Jassi Bhagwan, Sanjeev, and here's a date and a time. And it's the same patient, Jassi Bhagwan, Sanjeev, and a date of time. We looked at his descending aorta. Look at the coarctation of aorta, which was carrying for last 12 years of his life. And when we looked at the gradient, the proximal gradient just before coax was only 4 meters, and the gradient across the coax were almost 36 or more millimeters of mercury. And looking at the significant gradient, at least more than 20 millimeters of mercury, this guy was carrying coarctation of aorta for more than 12 years, with ECG changes in echo, with concentric LVH, 7 episodes of epistaxis along with the renal surgery. And unfortunately, nobody looked at it. And he's telling you, look, whenever my BP is controlled, what exactly happens whenever BP gets controlled? My pressure gradient across this coag goes down dramatically. And when it goes down dramatically, what happens? My legs, they start paining horribly. And that's what he was complaining all the time. And that's how it makes a difference. Like, if you happen to see an LVH, take my word, the most important part of echo in clinical practice for hypertension is just put a probe across aorta. And I can vouch of saying that at least 1 to 2 cases every 3 months we are getting a coarctation of aorta in the age of 40 to 50 years. And fortunately, the treatment is so simple today. Just have to go for retrograde from a femoral artery, go to this area, just put a balloon, dilate, and put a self-expanding stent. The guy will relieve of everything in the life, of a pain, blood pressure, and everything. And that's how it makes a difference. I'm trying to show you what has been available, or what has been the striking features for a physician in hypertension. Well, apart from that, where the physician can look at a role in LA pressures, RA pressures, aorta Doppler studies, renal artery Doppler is a very well expanded field as on today. then left ventricular hypertrophy and lower limb Doppler studies in cases of hypertension. Here's an example from my own lab. Here's a patient presenting with a renal artery stenosis. We can trace the whole renal artery in this patient from right from origin, from our aorta all the way to the renal pelvis. And if my renal artery velocity is more than 1 meter per second, renal artery aorta ratio is more than 3.5, with a toss at this point, we can comfortably say that this patient is suffering from renal artery stenosis. Incidence, virtually take my word, is almost the same. Like we do look at least 1 to 2 cases every 6 months, not 3 months. We do look in these kind of cases every 1 to 2 cases every 6 months. So role of echo in hypertension is not only looking at LVH, LV functions. Look, everybody will have a good LV functions. But question is, look for aorta Doppler and look for a renal artery Dopplers. And other things is what is more important is LA pressure, which I'll be showing in a different next subject where it is combined with diabetes. Let's move to my next presentation. Here's a person who's 62-year-old male. History of diabetes, hypertension, or irregular medicine, smoking and alcohol is positive. Pulse is 100, BP is 150 by 100, right arm supine, and we hear a systolic murmur in tricuspid area. If you look at his chest shows bilateral creps and bronchi, and liver is 2-finger breadth palpable tender. And if I club these all things together, I'm sure all of us will stand together with me. And like Dr. Singh, our teacher used to teach us an entity which we used to call this as hypertension with CH. Now, beautiful echo, and where majority of us will stop. Here is a plaques window, good contracting LV, 2-chamber view, anterior septum, anterior wall, and inferior wall, 3-4 chamber view, septum as well as the lateral wall. Here's the anterior septum and the posterior wall. No significant mitral and aortic regurgitation is present. So we have a normal LV systolic functions. But the question is, when we measure this anterior-posterior diameter of this LA, it was more than 22 millimeter per meter body surface area. Hence to say that possibly we are dealing with dilated LA. Now the question is, why dilated LA in a patient who is a diabetic and hypertensive? That's what I'm going to address in the next couple of minutes. I went to do a diastolic function evaluations, and that's what we do as on today in a clinical practice ever since Sharif Nage published his data in 2016 of evaluation of a diastolic function in normal and abnormal LV functions. We look at an EA ratio, we look at E prime lateral, E prime septal, and went on to do a TR jet velocity. So 1 parameter, 2 parameter, 3 parameter, 4 parameter, and the final 5th parameter is LA volume index. Patient has got a small mitral regurgitation in apical 4-chamber view, very good contracting LV. If I put all these things together into this algorithm of evaluation of a LA functions in EA ratio, average E to E prime ratio, TR jet velocity, LA volume index, I classify this patient as grade 2. This is a slide from my own place. I just put up this slide to show that what do you mean by grade 2 diastolic dysfunction? Grade 2 diastolic dysfunction means my LA pressure is almost 15 to 20 millimeters of mercury. So various parameters which I encountered today in clinical practice, this is what the parameters are. What does this parameter suggest? So I have a patient who has got a dilated LA. I have got a patient who has got a raised LA pressures. And anything else for a patient who's diabetic hypertension? No, it's not that all we have done is. What do we understand out of this in a patient who's got a diabetic? What is the significance of this echo? And this has been addressed by this paper from Jack 2013. He says, look at the left volume index relation to long-term clinical outcome in type 2 diabetes. To determine the prognostic importance of early dilatation in patients with type 2 diabetes with no history of a cardiovascular diseases, this is associated with development of a cardiovascular disease and morphological changes in the heart may appear before the symptom rises. And the controls involves increased LA volume index is an independent incremental predictor for cardiovascular mortality and morbidity in type 2 diabetes with no history of a cardiovascular disease. My patient has got large LA volumes. And this simply tells you if I have a diabetes and my volumes are high, my LA is dilated, I'm already going to, if I'm asymptomatic, I'm already in stage B heart failure. Well, further, this is to address this particular paper published in JACC 2021. He says what are the number of people who are going to diabetic cardiomyopathy is they have an enlarged LA. Second, they have impaired myocardial relaxation. We did do a GLS in this patient, which was normal. Elevated filling pressure, the elevated filling pressures were there. Impaired GLS was not there. So at least 2 out of 4 conditions were already there. Another paper published in JACC 2021, it says that what is the definition of heart failure? If you look at the definition of heart failure, is structural heart disease. He says evidence of any one of the following: structural heart disease, abnormal cardiac function, elevated nitripeptides. We have one structural heart disease, and second is abnormal cardiac function in the filling patients. And if I've got an abnormal GLS, then furthermore to say that we are already in stage B heart failure. So much to say that in this patient, what we were doing? I just showed you a normal LV systolic function. I did not show you LV GLS. I did not show RV GLS. I did not show the abnormal LA strain in this patient. But these two findings, along with dilated LA, did classify this patient into stage B heart failure. And it's a time of fact when it's become symptomatic and goes to stage B heart failure. This is a slide which is not meant for a basic echo physicians. I just wanted to show this slide. The first one to get abnormal is a LA strain of a patient if you are looking for a heart failure with preserved ejection fractions or elevated filling pressures. So my take-home message from this slide is normal LV-RV systolic function even by GLS. Echo finding was important to diagnose raised LA volume index and reduce LA strain, which is suggestive of heart failure with preserved ejection fraction, stage B heart failure, diabetic cardiomyopathy, and they are independent prognostic factor for cumulative mortality and morbidity. Well, friends, we have just submitted a paper in Indian Heart Journal. We looked at 600 cases of diabetes and hypertension together. Finally, we are able to take out 336 or 37 patients, and the incidence of stage B heart failure is almost 52% of those subset of populations. Amazing. When every third or a fourth person in our country is a diabetic, please look at this LA volume index, which is virtually available in every goddamn basic machine of echocardiography. If their LA volume index is high, these are the people who are at a very high risk of developing elevated left atrial pressures. And they in turn land up to cases where heart failure with preserved ejection fraction is positive. Or if the LV systolic function goes down, they can go into a diabetic cardiomyopathy. Time is an essence to reduce their LA pressures by various drugs which are available in the markets. This is what a number of times I try to show. Look, echo is not a modality which is just pass of our modality. Put a probe, normal LV systolic function. Put a probe, abnormal diastolic function, and we are done. This is not bad. But say that whatever we do should do a perfect echo, and what is whenever the Sachin Tendulkar says that, we say the same thing. Ye dil mange more whenever you're doing an echocardiography, especially in our country when we have hypertensive and diabetic to a large extent. So what else we look in diabetes? We look, apart from a stage B heart failure, we look for a subclinical LV dysfunction. We look at a carotid intimal medial thickness, and now the more impact is on a carotid and femoral plaques by echocardiography. I'll spend 1 minute on this particular modality. Many of you must be doing a stress echocardiography in your labs, telling them you are normal. Many of our colleagues are saying CT coronary angiogram is better than a stress echocardiography. I see this particular phenomenon. If you happen to do a stress echocardiography, look for a carotid and femoral plaques. You'll give a much better answer than a CT coronary angiogram. Why? What the CT coronary angiogram does, it tells you anatomical lesion in the form of percentage. And then it tells you whether the lesion is significant or not significant based on luminal stenosis. If you do a stress echocardiography, which is normal, it means maybe you're having a lesion, but that is not significant. So your luminal stenosis maybe is there, but is less than 70%. If you happen to this femoral and carotid plaques together and you find a carotid of plaques or a femoral plaque, it means your coronary arteries are carrying plaques inside which are not significant, and you need a drug which can reduce your plaques in your body, so that you give them an answer for physiological testing apart from a so-called luminal testing. And that's what we have been doing in our lab now. With the patients coming to our lab, we are doing stress echocardiography along with the carotid and femoral plaques and subjecting them, whosoever is available, for a CT coronary angiogram. To prove our work, look, stress echo with carotid and femoral plaques is much better modality, easily available in our country, better than CT coronary angiograms. What else you can look in diabetic population is the flow-mediated dilatation to look for endothelial dysfunctions. Ankle brachial index, very simple method of looking at ankle brachial index. You have to measure your blood pressure. You'll have to measure the lower limb blood pressure by a Doppler flow method of posterior tibial artery. If the ratio is less than 0.95%, 0.95, believe my word, that patient is already carrying a peripheral vascular disease. And since everybody will treat coronary artery disease, everybody will treat diabetic cardiomyopathy, but nobody will look how can we prevent all these things in a time to come. And believe my words, this is a position which plays a significant role, not only in prevention, but reducing the risk of a cardiovascular diseases in our country in a time to come. Let's move to a very interesting case. Just 104-year-old female. I used to call her still young female. And she used to get breathlessness on and off. And by the time she is transported to the hospital from her home, which is about 20 kilometers away, and she used to become normal. And you know what? Her grandsons, great-grandson, दादी नाटक करती है. जब इसका घूमने का मन करता है, कहती चलो अस्पताल, सांस फूल रहा है. जब अस्पताल पहुंचते तो कहती चलो घर, अब पे ठीक हो गए. And this is what exactly happened 7th time in the hospital when she landed up. Fortunately, unfortunately, when I was there on that particular day, I was taking route, I was a little late. Pulse was 100, BP was 110/70, HGR was negative, temperature was normal, no clubbing, no sinuses, normal heart sound, bilateral bronchial creps and bronchitis. Well, majority of our people in our part of this country, which is closest to Haryana, they do smoke a lot of beeries. And if they're not smoking beeries, they are the people who have burnt chulas to cook their food at their homes. Well, no pedal edema. She was all well. ECG was normal sinus rhythm, no ST wave changes, only tachycardia was present. Look at this X-ray. I don't have to discuss an X-ray of this patient. Now look at this echo. This is 11:53.23 p.m. on 1st July. This is what echo we recorded at the time in the night. Subcostal window. Then we had to do an echo of this lady. At that particular moment, This is moderate amount of aortic regurgitation. Timer is now 12:01:22. And this is, you see a significant mitral annular calcifications, mitral valve is open, LV is good contracting, LA is little bigger in size, aortic valve is normal, tricuspid is normal, RV is normal, RA is normal. And this is what the echo is at another minute. This is what the Doppler flow pattern, many of our colleagues will say, small e, tall a, abnormal relaxation. Yes, excellent thing what they have picked up. Well, we went on to Doppler, and this is what the echo in subsequent times. We had this patient at 12:03, 12:04, and this was the pattern at 12:03. And if you look at carefully, next sentence is again, she's back to normal. And I often ask this, what exactly this patient was having at this moment? And when we were recording this echo, the attendant said, sir, she's breathless now. And she also was breathless at that particular moment. And if you look at these things carefully, what are the things which improves the change of positions? Myxomas, pleural effusions, left ventricular failures, apart from many conditions. But look at this echo, what we recorded and was giving an ample answer why these things are happening. Why this thing was happening is, now look at this echo of 12:01, heart rate is 108. 12:03, heart rate has dropped down to 67 beats per minute. Doppler flow normal, and suddenly at 12:02, my heart rate has jumped to 165, and it's not regular. Patient has gone to atrial fibrillation. 12:04, now she's back to normal sinus rhythm of 108, and this time she was really breathless. And when we did a Doppler at the moment, you can see that occasional E and A wave is seen. This is E and A wave is seen. These are all E waves, what we could see over there. She was having intermittent atrial fibrillation and she was going back to normal sinus rhythm at the same time. And that's what we wanted to show is, like, this is what a Doppler before and this is what the Doppler is afterwards. In sense, we say that classical case of recurrent atrial fibrillation producing raised LVTP, breathlessness not identified previously. It is questioned. It's a very true hard fact of the life. Unless until we see, we cannot decide or we cannot comment. In summary, we see a case of a non-valvular atrial fibrillation commonly seen in older subjects, presenting with intermittent phenomena. And before this, that's another work we are doing in our lab is, we are looking at this heart failure with preserved ejection fraction and looking at the incidence of atrial fibrillation in this patient with the help of strain rate, LA strain imaging. And there's a paper like you can predict incidence of atrial fibrillation in heart failure with preserved ejection fraction by a cutoff of LA reservoir stains. And we can prevent this atrial fibrillation possibly in this subset of populations. And unfortunately, this is what I thought when I was president for Delhi branch of a CSI. I used to say, can we prevent atrial fibrillation in elderly population? That was 2012. Believe my word, no company came forward at the time. And the paper was published in 2022. Look, we can prevent atrial fibrillation in elderly population if we look at their LA pressures by LA strain. And this is what is same patients, no atrial fibrillation and atrial fibrillation in follow-up when they have a reduced reservoir strain. This is a normal reservoir strain and here's a reduced reservoir strain. LA volume index still remains the same. And before that LA volumes changes, the reservoir strain changes in these subset of populations. So another take-home message from this slide which says prediction of atrial fibrillation in heart failure with preserved ejection fraction, incremental value of LA strains. It is a physician again who can look at this population of role of echocardiography. So in breathlessness, we can look for RV pressure evaluation, mean pulmonary artery pressure, RV function. I did not spend much time on this because majority of you know what is an RV function is. Stroke in one example in echocardiography carotid transesophageal, and I just forgot to add a vertebral artery Doppler scan, because vertebral artery Doppler scan, what we did recently, we were able to diagnose vertebral artery dissection by echocardiography in a young person who presented with a stroke with cerebellar signs. Very easily, we could show a flap of a vertebral artery. And that's how we can look at these people in echocardiography. Giddiness, of course, all these kind of factors. We look at a peripheral vascular disease, intermittent claudication, toe gangrene, venous Doppler study, we can look for leg ulcer, varicose vein, valvular incompetence, and pedal edema. This is one place which plays an immense role in a clinical practice. Smokers. These are the people who present majority of time with localized, single place, significant stenosis, isolated stenosis in coronary artery disease. They don't present with cardiomyopathies. If you look at the intermedial thickness, they're significantly high. And if you look at their FMD, flow-mediated dilatation, that is first to get disturbed. And they present not only in the heart, they present in peripheral vessels also. And what is more important is look at their ankle brachial index. As I said a few minutes back, very simple method of taking a blood pressure and then taking a pressure in the lower limbs using a posterior tibial artery. Child, I'm not going to discuss the child over here. Pregnancy is one feature which Dr. Ashok Garg is sitting over here. We were talking about things like something like cardio obstetrics. And I coined a word in this particular modality, impending cardiomyopathies. One of my patients who had come with a dyspnea and palpitation, we did an echo, good ejection fraction, good normal LA pressures. But soon after that, the patient came back with cardiomyopathy. Look what we did, we missed the subclinical LV dysfunction in that particular lady because we did not do a GLS. My heart rate was almost more than 100 plus. And as now, whenever my patient comes to my lab for getting an echo done if she's pregnant, 3 things I'll always do in my life apart from routine echo is look at their LV GLS, look at their LA strains, and look at their RV strains. And it really gives you a lot of information whether this patient is going to have a cardiomyopathy or not. So this is what a physician without learning echocardiography. This is a physician who has learned echocardiography. It all depends on you. You want to become this or you want to become this. In conclusion, I would like to say wide implication in clinical practice of a physicians. I like to add a wide implication in the clinical practice of a gynecologist also. One of my students from Tamil Nadu, she said, "Sir, I want to learn echocardiography." I said, "Why do you want to learn echo in gynecology?" She says, "I'm living in a smaller town and if patient develops a breathlessness, I don't know how to look for a cardiomyopathy." And one of the batches, she came out with one of the finest students during the training programs. Right from a normal subject with mild breathlessness to severe, a physician is incomplete without the knowledge of echocardiography. With these 3 words, I would like to put a stop on this my talk. And thank you very much for bearing me for last 45 minutes with my so-called thoughts. My work for last almost 39 years of echocardiography practice. And I like to happy to take up questions, whatever are there from the audience.
This is one of
Dr.
our
Ankit, sir,
blockbusters webinar. I salute you. Yeah, Arusi. Hello, technical team. Yeah.
Yes, sir. Yeah, there.
So I think, yeah, you can see the chat box. If there is any question, please let us know.
Well, let him
Dr. Akash Singh have joined, and I welcome Dr. Akash Singh, Dr. Vijay Patni here. I think let Dr. Vijay Patni first respond about his talk. Dr. Patni.
Yeah. First and foremost, congratulations, Dr. Akash Gupta. As usual, you were supposed to talk the way you talked. So we really learned a lot, and being more a diabetologist is extremely important modalities in diabetic patients. So you did point out few elements which we need to look into, and they can at least give us an idea about particular one such area, that is diastolic dysfunction, and thereafter the cardiomyopathy associated with diabetes. So thank you, Dr. Rakesh Gupta. I don't think whatever he presented need any clarification, but do you think that physicians need to have echo at their clinical establishment, each physician, or what do you think, Dr. Gupta?
I showed you a slide. How does a physician look without an echo machine?
I agree with you. That
Not looking at the person as total. Knowledge-wise, you become extremely different. I can tell you a very simple example. How do you treat a patient come to a shock in your clinical practice? If you have an echo, I'll just give me a 2 minute. If you have an echo, I will look at an IVC. If it's small in size, volume deficit. Normal size, then I'll start looking for other causes. If it's dilated, I understand there's something to do with the right side disease or a pericardium. I look at a 4-chamber view. If I say normal valves, normal LV systolic function, then I look for a diastolic function. If it's normal, then what else is left? I start thinking of infectious diseases. The treatment of choice is entirely different. My colleagues in intervention, like intensive care, do not agree with me. If a person is of a shock, of a cardiogenic shock, you will not give a noradrenaline. What you will do in a noradrenaline, you will kill that patient by increasing the preloads. If a patient is of infectious disease with shock, you need to give a noradrenaline. If a patient is of a cardiac origin, you need to give something which reduces the preload and afterloads. That's a dopamine and dobutamine combinations. And where else this thing would be done in echocardiography? Nobody else can do this apart from echocardiography. I've seen many people, we used to teach many people how to do a cannulation of internal jugular veins. Now people are using the same thing in anesthesia department. They are doing now cannulation after 20 years when we talked about somewhere in 2000s. Now people are utilizing the radial artery puncture by Doppler probes. Things have moved to a different directions. In one of the hospitals, you know what they said? I can't do a pericardial pleural tap, not pericardial, pleural tap without ultrasounds. So do you think the physician is complete without an echo ultrasound machine?
Yeah, that's what I wanted to actually reiterate. So that's what I wanted to reiterate what you said, yeah.
Dr. Patni is also very conversant with the echo training. I think, sir, I really remember that Delhi when I 1 week I spent with you, and it was really what I learned today from for echo, it is from you itself. So Dr. Akash saying your initial comment, then Dr. Sokgar will respond.
Actually, echo is now a extension of clinical acumen because it is compulsory, because we generally have echo machine in our ICU, we have echo machine in our OPD. Everything is, all the patient management is based on echo. Can we assess the duration of diabetes by doing a cardiac echo?
Duration of a diabetes by cardiac echo, I don't think we can do that.
Yeah.
So we cannot do. Okay. So
but I can diagnose that whether this patient is going to congestive heart failure or not.
Heart failure. Yeah.
But good question you have put in. Let me just look at this particular phenomenon. Our center is hell-bent on doing the trials now.
Right.
We have 10 trials going on round the clock. And our aim is to publish a paper, not in India, American Society of Echo, European Association of Cardiovascular Imaging, without paying a single rupee of a registration fee. Single dollar or euro in registration fee. They charge nearly thousands of a registration fee. We don't want to give even a single dollar or single rupee to present our papers.
Dr. Sokgar, Yeah, Dr. Asokgar, sir, let Dr. Asokgar first respond. Sir, any questions, sir, from your side, sir, Dr. Asokgar?
Sir, Rakesh sir, just one question. Sir, in first case, you tell there was a systolic murmur in a case of acute MI. So there was was there particular reason about the systolic murmur, sir?
Mitral regurgitations,
Yes, sir. Yes, sir. Yes, sir.
papillary
Thank you, sir.
muscle dysfunctions.
Yes, sir. Yes, sir. So I am Sir, I am
Please.
totally agree with Rakesh sir's statement that each and every physician, whether he is practicing internal medicine or diabetes or chest, whatever, he must learn echo, and that is most important part of his clinical practice. So I'm 100% agree with Rakesh sir.
Exactly, sir.
Sir,
So I think it is a very, very important modality. Yeah, Dr. Akash Singh.
My observation is that echo, basically, I also done my training under Dr. Rakesh Gupta 10 years back and taken the accreditation for echo. But it turned out to be a pretty time-consuming business, and ultimately I got a technician now. So now what I'm seeing is none of the cardiologists is doing echo by themselves. Everything is being done by technicians, and tissue Doppler is very scarcely done because of the time constraints and all. So, sir, what are your comments about it, sir?
Dr. Akash, first of all, is not cumbersome. If you are doing it regularly, we do a complete study in about 10 minutes today. We have a software which gets transmitted all reports into the reporting formats. It all depends like how you are focused. And I can assure you, like if you happen to visit our lab, every setup has got a different format. Patient comes with a breathlessness, we'll focus on RV. Patient comes with the LV side, we'll focus on LV. Doing a tissue Doppler is a very simple thing, and we are not doing tissue Doppler. We are doing a GLS, RV stain, LA stain today. And one more thing I say, we earn our livelihood because of other people. I'll quote an example. A person, a lady came from a very CDOC center of a Delhi, very famous, renowned center. What was his problem? She was having a breathlessness. She was having tachycardia. They had done beautifully everything. In the end, they did an angiogram, they did CT coronary angiogram, they did a lung function test. You tell a modality which was not done by them. And she was prescribed beta blocker after. And she says categorically, whenever I take my beta blocker, my breathlessness gets worsened. And that's how she was referred all the way from Vasant Vihar to our place, which is almost 30 to 40 kilometers away. You know what she was carrying? Imagine. She was carrying dynamic diastolic dysfunction wherever she walks. Her LA pressure used to build up. If we did the same thing, we did a stress echocardiography, we demonstrated that her LA pressures are building after stress. And what we did, we stopped beta blocker, increased the dose of ACE inhibitor with ARBs. Her tachycardia disappeared, her breathlessness disappeared, and she was very happy after that.
Dr. Rakesh Gupta, sir, now recently I am using the echocardiography machine, and I don't have any technician, I do myself. But that machine is also enabled with the artificial intelligence. So I think even the tissue Doppler study, which Dr. Akash mentioned, we are doing in a fraction of seconds now. So what's your comments are about the AI used in the echo?
Absolutely agree. You know, like we should change our machine next 5 years' time. Government gives us money to change our machine. Use depreciation. Machine will be free all the times.
Sir,
So all new machines, they are coming with artificial intelligence. You show them a Doppler flow pattern of mitral valve, press a button of measure, they'll only measure mitral valve. You show them tissue Doppler imaging of E prime septal, E prime lateral. It automatically measures E prime septal, E prime lateral and give you average automatically. Even LA volumes, they are not doing, you have to do it manually. But GLS, RV strains, they are doing it normally. And this is available not for a high-end machine. Like I'm using G, like G R206 model, gives you everything very quickly. So artificial intelligence is going to make a life easy. Second thing for Dr. Akash Singh, I'll say, look, if I'm doing an echo and a technician is doing echo, there's a gross amount of differences out there. Because when I'm doing an echo, I'm looking what exactly I have to look into it. When the technician is doing, he's not looking in echocardiography. He's trying to look and finish the echocardiography.
Exactly, sir. So I think that Lakshman Naik has asked one question from the Bhatkal. Sir, would still active dobutamine in a patient of cardiogenic shock with systolic blood pressure less than 80 and with tachycardia? Sir, what is this question?
He's trying to say that he did not mention about the ejection fraction, whether it's acute or a chronic. If it's a chronic, obviously dobutamine is not going to help so many things because this is the patient of resistant or deteriorated congestive heart failure.
Exactly.
If this patient is an acute phenomena, obviously, if this kind of a patient is there, I'm going to use either IABP or take this patient to cath lab to do my interventions. So it depends on which conditions. What I was saying was patient comes in shock with a poor LV systolic functions. I look at my LA pressures. If my LA pressures are high, I would like to use dopamine with dobutamine combinations. If my cardiogenic shock is not because of this cardiogenic shock, it's because of an infectious shock, I'll try to use a noradrenaline.
Exactly, sir. So I think, sir, we are only 4 minutes left. So, sir, let our physicians learn about something that finally your take-home message for the physicians today.
I only say that please learn echocardiography.
Exactly, sir. So
The
now
smaller the town you are the best person to learn echocardiography. And believe my word, you will be ace above than rest of your colleague if you learn echocardiography.
Exactly, sir.
People will envy you that you have learned echocardiography. It's not only that, you'll serve the nation, you'll serve the population. The government has given, the population, the society has given so much to us. It's a time to repay back to them by adding one more modality in your armamentarium for better serving of these populations. And diabetes and hypertension, they are going to kill us in the next 15 years. We don't need an atom bomb. We have atom bomb in ourselves right now. If we don't stop, this atom bomb is bound to explode. Look, every third or fourth patient is a diabetic today. So what will happen? We have to stop this atom bomb. We cannot stop it. We can slow the progress of this atom bomb before it explodes. And hopefully by the time, we should be away from this world.
Great, sir. Great. So now, Dr. Ashok, your take-home message for today.
The same take-home message, sir. Every physician must learn how to do echo and never depend on the technician. Do it at yourself.
Great, sir. So, Dr. Vijay Patni, can you conclude the whole webinar?
Yeah, definitely. I think a lot of take-home messages today. I think one example which he said is the cardiogenic shock. Now the patient comes with a shock, and an echo can give you quite a good amount of inputs that you can plan out your therapy. And that's what a physician should know. ICU guys should know. And secondly, is that the technicians is more mechanical. I mean, just they are going to give you a mechanical picture. They are just going to few parameters they are going to give you and then finish it off. They are not going to look into the cause of the problem. So definitely, if you can do it, it is always good. So thank you, Dr. Rakesh Gupta, sir, and Dr. Ashok Garg, sir, for moderating the session. For 10K Singh, as usual, Dr. Akash Singh is always there, and myself, and we conclude this session. We ask Dr. Asim to conclude the session today.
Thank you. Thank you so much. I would like to start by thanking Dr. M.K. Singh, sir. Thank you, sir, for bringing us one more episode of CME India. Thank you so much, Dr. Rakesh Gupta, sir, for sharing all the practical insights and accepting a last-minute invitation. Thank you so much, our panelists, Dr. Ashok Garg, Dr. Vijay Patni, and Dr. Akash Singh, sir, for sharing your knowledge, time, and wisdom with us. With this, I would like to conclude today's topic and see you for the next time. Thank you.
This is what technician talk is. This is what technician talk is.
Yes, sir. Yes, sir.
Good.
Now we can take home my message.
Yeah.
This is not focus talk. This is technician's talk.
Yes, sir.
This is technician's echo.
Yes, sir. So, sir, brilliant talk, sir. I think this is really going to hit the market. Our Team India people are very happy today. Thank you, sir. Dr. Ari also thank you to Dr. Ashish Saxena. I think due to some medical emergency, he was not able to do today. So, sir, thank you again very much, sir. Thank you. Thank you all.
Good night. Stay safe.
Thank you, sir.
Thank you.
Good night.
Good night, sir.
Thanks.
Good night.
Good night.